Hello everybody, in this video we will explore the features of nephrotic syndrome and provide some useful tips to help you refresh your knowledge about the condition. Nephrotic syndrome occurs when the filtering units of the kidneys called the glomerular are damaged, causing them to leak proteins into the urine. Now before we start, let's take a look at the medical mnemonic. Alright, so let's take a look at the very important diagram. Now you recall that the glomerular capillaries helps in the ultrafiltration of water and smaller solutes while it prevents albumins and other bigger proteins from breaching what we call the glomerular filtration barrier. And one of the major components is the endothelial cells. So endothelial cells has fenestrations that helps in filtration. On the surface of the endothelial cells is glycocalyx, a sort of a mesh gel-like substance that lines the surface of the endothelium. It is usually negatively charged. Now the importance is that the albumins and proteins that are negatively charged are not able to penetrate the barrier because of the charges. All right. The other component is the glomerular basement membrane, which serves as a scaffold for the podocyte as well as the endothelium. And the podocyte, which is a complex structure, which has a slit diaphragm. You can see the brownish structure which joins the foot processes, which is also sort of intertwined with each other. And the purpose of this is to also help with filtration, because the slit that is created is used to sieve or to filter the solids in the water that comes into the kidneys. So it's important to also note that the albumin levels of the urine should not exceed 30 milligrams per day. 30 milligrams per day. And the protein levels of the urine should not exceed 150 milligrams per day. Now, the barrier is to help prevent leakage, but unfortunately, nephrotic syndrome may damage one of these components, being the endothelial cells or the glomerular basement membrane or the podocyte and its foot processes. For example, minimal change will affect the foot processes as well as the podocytes. So nephrotic syndrome sort of breaches or destroys, damages these components that we have here. Very, very important for the function. So the proteinuria that we talk about in nephrotic syndrome is within about 3 to 3.5 grams per 24 hours. This is the nephrotic range. If it is only the albumins, we will call it selective albuminuria. And if it is mixed with other proteins, then it's just going to be a general impairment with permeability. So this is what happens, and this is the reason why the proteins are being lost. And so this is going to lead to albumins being decreased in the blood, usually less than 30 grams per liter, but in reality, it can actually be less than that. Now let's discuss edema, which is a major clinical feature of nephrotic syndrome, and there are two hypotheses, one of them being the underfield theory. Before we discuss that, let's talk some basic physiology. Now, assuming that you have a capillary here, and you have the interstitial space also here, and the veins or the venules, there is fluid in the capillaries. That fluid exerts some pressure on the walls of the capillaries, and that helps filter the fluid from the capillaries into the interstitium. That force, we're going to call it the hydrostatic pressure of the capillaries. So that is dependent on the amount of fluid in the vessel or in the capillaries. The more fluids you have in the capillaries will lead to an increase in the hydrostatic pressures of the capillaries, and its purpose is to help take the water or the fluids from the capillaries and put them into the interstitial space. In contrast, we also have proteins in the capillaries. These proteins serve to rather bring the fluids from the interstitial space into the capillaries, which is in contrast to what the hydrostatic pressure of the capillaries does. So hydrostatic pressure of the capillaries is for filtration, and the oncotic pressure of the capillaries is rather for reabsorption. Now, on the other side, we have the interstitial space, which also has a hydrostatic pressure of the interstitial space, and that also serves to filter fluids from the interstitium into the capillaries. And a similar thing with the oncotic pressure of the interstitial space, which will also serve to bring the water from the capillaries to itself or into the interstitial space. So that's very important. Then after that, there are certain lymphatic vessels in the interstitial space. These are usually some blind end lymphatic vessels that takes the fluids that comes into the interstitial space and puts it into the venues. So the point to note is excessive increase in the hydrostatic pressure of the capillaries leads to filtration of fluids into the interstitial space, and a decline in the oncotic pressure of the capillaries, which we see with nephrotic syndrome, would also lead to filtration of fluids into the interstitial space. The net effect is that the interstitial space is now becoming overwhelmed with a lot of fluids. Now, there is this blind end lymphatic systems that is supposed to remove the fluids and put them into the venules. Since the fluids coming into the interstitial space is really overwhelming for the lymphatic systems, the effect is that there is more fluid remaining in the interstitial space, which presents as edema. So the underfield theory is saying that there is a loss of albumin because of a breach in the glomerular filtration barrier, and that leads to a decline in oncotic pressure of the plasma. So we have the oncotic pressure of the plasma here declined. When that happens, it is going to lead to filtration. So there is a lot of fluids going into the interstitium. During that moment, in fact, the hydrostatic pressure could also be elevated, and that can also help push more fluids into the interstitial space. But at some point in time, the fluids goes into the interstitium, and so the vascular compartment here in the capillaries becomes low. So there is a reduction in plasma volume. There is a reduction in plasma volume. And this is why we call it the underfield theory. So there is a reduction in plasma volume. And you do recall from physiology that whenever there is such reductions, it is going to trigger a response from aldosterone, which would lead to a sodium water retention with the purpose of trying to compensate for this reduction in plasma volume. And so this sodium retention would still sort of cause more problems with overwhelming the interstitium with more fluids and leading to more edema. So you recall from the underfill hypothesis that there is a reduction in plasma volume, hence underfill, which triggers a response from aldosterone and leads to a sodium water retention. Well, the overfill theory is proposing that the sodium water retention is rather due to a defect in the tubules, and it is not a compensatory mechanism. The proposal was made after some studies showed that the sodium retention had dropped even before the serum albumin levels were also decreased. And moreover, many patients with nephrotic syndrome have normal or raised intravascular volume. Hyperlipidemia. In nephrotic syndrome, there is excessive loss of albumin from the blood, usually less than 25 grams per liter, which in turn causes the serum colloid osmotic pressure, in other words, oncotic pressure, to decrease. In an attempt to compensate the low oncotic pressure state of the serum, there is a reactive lipoprotein synthesis by the liver, which leads to a hyperlipidemia as well as fatty droplets persistent in the urine. The excessive lipid synthesis can in part be explained by the decline in the activity of lipoprotein lipase enzyme. So patients with nephrotic syndrome are prone to infections. And remember, the proteins that are lost are not only albumins, but they can also be immunoglobulins as well as complement proteins that are necessary in the fight against infections. The use of medications that are immunosuppressive agents can in fact lower the threshold for infections. The excessive interstitial fluids that occurs in nephrotic syndrome can serve as a culture medium for viruses and bacteria to thrive. So the way forward is to prevent by immunization. But in the case of infections, you would like to strictly consider the renal creatinine clearance or the GFR when you choose any antibiotics for such patients. Hypercoagulability state. There is loss of proteins that prevents clots, such as antithrombin 3 and plasminogen, while some clotting factors remain elevated. So this becomes a big risk factor for the development of deep vein thrombosis and pulmonary embolism. Prophylaxis is preferred to help avoid such a devastating complication. Hypocalcemia may also be seen, and this is due to the loss of albumin and may not reflect true hypocalcemia. Thank you, and I hope this was useful. If you enjoyed it, then hit the like button and subscribe to the channel. Bye.